All right, good evening, everybody. Hi, Mark. How are you doing?
Good, Jan. How are you doing? How you
I'm
doing?
good. This is going to be fun.
Is it though? I don't
It
know. We'll see.
is.
We'll see.
Well, I know we have a big crowd tonight, so people are starting to make their way in, but let's get started. Welcome to tonight's Wu University presentation. One is too many when you might want to treat with Dr. Mark Blumenstein.
I like how you kind of like paused through that. Like,
I
who
had
came
to
up
give
with
that. I
who
wanted
came
everyone
up
to
with that
see.
stupid title?
I, I read it. I said I have to slow down on this one. It's a good one. So I'm your host, Dr. Jennifer Stewart. And thank you to Tarsus Pharmaceuticals for providing an educational grant. So just some reminders for each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent with OE tracker numbers. We'll display the QR code at the end of the event if you have the OE tracker app on your phone. CE certificates will be emailed within 4 weeks. And make sure you ask questions throughout the presentation using chat or Q&A.
Yeah, I know. I'm slow. There.
And here's where you can find it on your phone.
I was looking for it on my phone, so I couldn't find
There it is. So I am very honored and excited to be here tonight and be moderating for a Woo You favorite. Dr. Blumenstein is the Director of Optometric Services at the Schwartz Laser Eye Center in Scottsdale, Arizona, and President of MRB Eye Consultants. Furthermore, he's the Chairman of the Education Committee for Vision Expo. He served as the Chairman of the AOA Continuing Education Committee and served on the board of the Ocular Surface Society of Optometry, as well as a founding member of the Optometric Cornea, Cataract, and Refractive Society. He has also served as the president of the Arizona Optometric Association, legislation chair, and president of the board of the Arizona Optometric Charitable Foundation. He's delivered over 1,500 invited lectures worldwide, served as principal investigator in over 20 clinical trial and consults with numerous industry-leading pharmaceutical, biomedical, and information technology companies. Welcome again to Woo You. I'm going to turn it over to you, and
it.
I'll be back at the end.
Thanks, Jen. I do also want to say, if you look at my picture, doesn't it look like my glasses are clear? Like they're just fake because I want to look smart? Is it working?
100%.
Okay, awesome. Very cool. Here are my financial disclosures as we talked about. It's kind of a small slide. I'm trying to Carpecchi these. I wanted it to be the whole slide. I'm working on that. Also, all of my financial relationships have been mitigated. I'm going to be 1,000% honest with you. I have no idea what that means. So if that offends somebody that I'm mitigating, I'm not doing it right now, so you don't have to worry. It's the mitigating is not happening as we speak. It already happened, so we're all good. So one is too many when you might want to treat. And I know that the Woo You has been advertising this as, your creepy callers, your lid discussion, and it's all going to be kind of like this three-parter. And I have two other colleagues, our colleagues that are going to be speaking after me, not tonight, but at another part of this series. So I get to be the amuse-bouche, if you shall. I'm going to hopefully whet your taste for the fact that this is a condition that you should be looking for, that you should be treating. And I hope I give you a compelling enough argument. But even if I don't, you're all getting CE just by virtue of being here. The other thing I want to do is just make sure everybody is paying attention. Patients ask me all the time, "How are you?" And I'm honest with them. I usually tell them I have diarrhea, or I'll say, I don't know, I've lost the will to live. And sometimes they're happy about that. Other times they're like, maybe I need to see another doctor. So in the comment section, if you can, if you could just, if I asked you, how are you? Please type in there how you are. Okay. And I will look at those afterwards. Really appreciate it. So let's start off this talk by presenting a case that I've been presenting a little bit because it's a colleague of mine. Not a colleague, he's a friend. Okay. So yeah, I'm not seeing a lot of comments coming through. So, how are you? Let's get those going, people. Put those in the chat. Okay. So what's your emergency? 911. 911. Now, I have to start this off by letting you know, I was, and I never really advocated for managing Demodex. I never thought that it was on my radar. I bought the microscope to kind of pull the lashes at that time, 10 years ago, give or take. But I never really subscribed to the belief that there was a whole lot of symptoms associated with it. And to me, one of my biggest challenges is when I am managing a patient is to get them to buy into what I'm selling, right? You tell somebody they need reading glasses, well, they can tell because they can't see. You tell somebody they need distance glasses, they can tell they can't see distance. But when you give them a treatment advice for something that you can't even manage, or you tell them you see something and it concerns you, but you don't have a treatment for it or a good treatment, patients are going to be like, okay, thanks for sharing. Not a big deal to me. Well, this is Bobby. Okay, Bob Dubnow. Bobby is actually a police captain. I always say that he's a fire captain. Now, real quick back history on Bobby. Bobby, his daughter is the same age as my daughter. My daughter, who is now 27, who's a dentist. Her and his daughter Shoshana, they basically kind of were in a preschool together. My youngest son, who is a second year optometry student, going on to a third year now at NECO, what? He and their other son, I think it was Zachary, were good friends. So I've known these people for over 2 decades. And these are the type of people that would literally call me up and say, hey, um, I'm thinking maybe some Oakleys. Do you think you can hook me up with some Oaks? And it'd be like, sure, Bobby, right? But not going out to dinner, not doing any cool stuff like that. Anyways, so Bobby started calling me, I don't know, middle of 2000, the aughts, whatever those are, and he noticed that he had something on his lid. He had a bump on his lid. Okay, I met him in front of the mall once, diagnosed him with a hordeolum. It was nasty. Told him do the warm compresses, do all those things, excitement. Put him on a amoxicillin, had him, warm compress, all that. It might have been 4, 5, 6 years later. Okay. I think we've already been through a couple Oakleys. Bobby's calls me up. He goes, you only got that bump again. Okay, we treat it. Right around 2022, give or take, he calls me and he's like, I've got another one of those bumps. And I feel like they just keep coming back faster. And I'm seeing them more. So I said to him, I go, you know what? I go, come into the clinic. I want to evaluate you. Okay. So now, we're here. It's September 2023. It's almost a year after that. And Bobby's in the clinic doing the normal stuff. And if you look on the lower right-hand corner, you see the picture of that helicopter. Do you see the red kind of bed that's down there? Well, that is a woman that fell off of Piestewa Peak. And those are the pictures that you see there. She was 70, I think, and she was hiking. And if you come to the valley, I mean, you see this beautiful escapes. This is right in the middle of Phoenix. The problem is that if you fall, rut row. So Bobby's team picked her up. And the problem was, if you look at that picture, she started spinning like crazy. Some of you might have seen it on the news. Well, Bobby was the guy who had to go in front of the camera and be all like, we did everything we possibly could. Okay, needless to say, um, that woman probably makes more money than all of us combined. Okay, yeah, she did okay by saying no, thank you to the Phoenix Fire Department. So Bobby calls me up and he's like, dude, it's back. Okay, now I don't know how well you can see it, but he has a flat choroidal lesion also. But more importantly, when you look there, you can start to see the beginning of another hordeolum. Now, at this point, I've changed my modus operandi. I'm like, why is all of a sudden Bobby getting more hordeolum? There's got to be something different about his eyes. Well, one of the things that I did when I was evaluating him is I realized that we're going through these clinical trials. I'm hearing about more about management and treatment of this condition called Demodex, and I had him look down. Now, over the next 40 minutes or so, I'm basically, hopefully, going to give you a compelling enough reason that you look at somebody's lid, and if you see all this schmutz on their lid, your mindset is not today, my friend. Not today. What do we say to Demodex? Not today. Oh, Jen, I should have called it that. What do we say to Demodex? Not today. Any of my Game of Thrones friends out there, you guys know what I'm talking about. So, yeah. This is Demodex blepharitis, people. Okay. Now, it is a common eyelid allergen. Okay. More importantly, it is a common overgrowth of a skin mite that is literally on every single one of you. Okay. All seven of you that are on this call right now, it is on your body. So if you're thinking, ew, ew, you nasty. That's disgusting. No, you have it. And I always like to kind of talk about the origin story of this condition because I think patients like to feel like, oh my God, how did this happen to how did this happen to me? And the reality is this, is that these skin mites are basically on your body. They eat a little bit of dead skin, but more importantly, they're in dust. They're pretty much almost everywhere. But the bigger truth of the matter is that probably when you were being held by your mom or your dad, and for the first time, or even a nurse or anybody, the transference of these mites just happens, or more importantly, from the dust, from anywhere. So here's the harsh reality, people, is that this is something that is extremely common. Now, to see the type of overgrowth that you see is not common. And more importantly, that is what represents some of the challenges and problems that we have. Now, some of you might be thinking, you know what, Mark? I don't see a lot of Demodex in my office. And to that point, I'll say, then you're not opening your eyes. Then you're not really looking for it. And I get it too, because I think back in the day, people were all like, oh, you know what? You need to have itching, where people itching right here, right there, right? Oh, somebody went to the Astros game last night. Get some rest, buddy. Get some rest. More importantly is that traditional itching and irritation that you would get there. Well, no, that might be the end game. That's like to me when somebody says to you, I don't have dry eye because my eyes don't feel dry. And everybody on this call here, is this a call? No, this webinar. Everybody here on this webinar knows that dry eye is not feeling dry. Dry eye is fluctuating vision. Dry eye is an awareness of your eyes. Dry eye is an abstract definition of a concomitant amount of symptoms that our patients just don't know, and we call it dry. To me, we get hooked on the term blepharitis. We think inflammation, lids. Well, it could be minor inflammation. It could be just microscopic inflammation. But the reality is that there is one simple way to determine whether or not your patients have an overproduction of these mites. And we're going to talk about that in a second. But the reality more so is this, that there was a study that was done, okay? And I actually was part of the study. We took, I think it was 1,200 people, okay, give or take, 100 of them were my patients. They came in, I looked at them in the slit lamp, and I basically evaluated whether or not they had Demodex. Do they have it? Yes or no? Okay. The second thing is have they been diagnosed with dry eye? Okay, yes or no. Moreover, do they wear contacts? Yes or no? Then the question was, do they have cataracts? And in this study, I was blown away. And I even called somebody over, who had asked me to be part of the study. And I just said, I'm shocked. And I will challenge you guys to go into your practices tomorrow. Well, I'm going to challenge you actually to diagnose it. But the reality is that 58% of the people in this study had Demodex blepharitis. Now you can extrapolate that number amongst the population, and you come up with, about 25 million patients that have this. 56% had cataracts. Okay, makes about sense. Okay, 60% of these patients also have concomitant dry eye. And more importantly, I think that number kind of is around the same as what they have for meibomian gland dysfunction. I don't want to step on Paul Karpecki's toes, so I want you to make sure you come to his lecture. But the association between MGD and Demodex is about 56, 55%. But look at the contact lens intolerance. And I know it's a low number. And if anybody out there is keeping track, if you're not, concomitantly watching the pit while you're doing this or eating dinner or driving in your car, but it's something like 28 patients. But 26 of the 28 patients with contacts had Demodex. And for those of us that are managing contact lenses, to think of things we can do to help keep our patients in their contact lenses more comfortably is really, really important. When we start thinking about dry eye, quality of life, and we start thinking about helping our patients, then the reality is that the lids have a direct impact on the conj, on the cornea, and more importantly, on that whole ocular surface. So the lid condition, or evaluating the lids, is extremely important. When we think about blepharitis, 2/3 of blepharitis cases are associated with this Demodex mites. Now, they can change, and the number of the mites actually correlates with the symptoms and the severity or the density of these collarettes that we're going to be looking at. Now, we oftentimes might be a little bit confused by the presentation. Now, for those of you who've been practicing for quite a while, you may remember hearing the term posterior blepharitis or anterior blepharitis. Some of you guys might, kind of like hearing, oh, is it seborrheic? Is it, is it bacterial? So if you look at these pictures here, yeah, you can see that kind of like seborrheic blepharitis on the left-hand side, right? The kind of coming off of the skin there, you can see it's more flaky looking. It's further down in the lashes. When you also look at the scurfs or that staph blepharitis, you see it's more kind of horizontal or linear. But when you start evaluating for Demodex blepharitis, then you have to think about where these lie, okay? So first and foremost, 69% are basically this infestation that kind of creates this. But the vast majority of these mites, the follicularum, live in the follicles. But there is a smaller Demodex, which is Demodex brevis. The brevis are about 0.1 millimeters in length, and they colonize in sebaceous glands, or they colonize in glands like the meibomian glands. And so if you think about it, right? Think about right here that when you walk into a room, you look for that red, kind of like almost kind of like raccoon face. You're looking for patients that have rosacea, the red, rosy redness to their cheeks and nose. But then you also really want to be looking at their lids because this, they believe, might be because of the brevis. This, they believe, is because of the follicular. Okay, so not only is this causing, blepharitis, there is a strong correlation between blepharitis, Demodex blepharitis, and meibomian gland dysfunction. Now, when we start thinking about looking at these bad boys, and some of the things that you need to know is that the life cycle of these is about 2 weeks. So they mature from 2 weeks, from the egg to the larval stage, and their lifespan is about 3 weeks. So if you were going to manage these little buggers, then what you want to do is you want to make sure that you're treating them at about, 3 weeks, getting rid of the mature ones, and then at 6 weeks, you're going to another 3 weeks, you're getting rid of the eggs, the larvae. The biggest challenge for us is that these are translucent. Okay. They have these elongated eggs or mites. They have these short clawed legs on them. And so they have like 8 claws and they can really wreak havoc in the follicle. Now, I was fortunate enough to be working with a slit lamp that uses AI to kind of magnify and enhance the quality of the lids. This thing was legit. Okay, it's a Firefly. I don't know if anybody has it. And then, of course, I say that, and then I start thinking about The Last of Us. I don't know, man. I don't know. Yeah, I don't think she should have told everybody that about that. But that's between us. If you haven't seen season 2 yet, but what I was able to capture is you actually could see Demodex mites coming out of the follicles. Crazy. And this is literally what it looks like. I mean, this is a follicle that has 1, 2, 3, 4, 5, 6, I think 7. See all those heads there with the claws? Yeah. Okay. Now, as I mentioned before, they reside in the eyelids, the cheek, the forehead, the chin, the neck. They're all over your patient's body. And that becomes important because when you start talking to your patients about managing these, you want to make sure they understand that you're not ever going to remove them. You're just going to limit them. Now, I mentioned a couple minutes ago about the fact that there is this correlation between hordeolum, but there was also a study that was done where they associated chalazion in pediatric patients. This is a study that was done in China, and they found 446 children with chalazion versus 50 controls, and Demodex was found in 53% of the patients with chalazion. None were found in the patients with control. Okay, think about that. Okay. for a second. So we know that they can be associated with that. There's also something else that I want you to kind of be cautious of, and this is something that Laura Perriman, LP, for those of us that know her, brilliant ophthalmologist, brilliant scientist, just quirky, just phenomenal. Okay. Laura actually called this the alpenglow sign. Now, I'm pretty confident that I can tell you that the alpenglow mountain range is in Montana, and that's where Laura's from. And she said that sometimes the way the sun hits the mountain range, you can look across there and you can see just peaks of trees on top of the mountain. So if you look in these pictures here and you can see the facial collarettes, but you see what she calls the alpenglow sign. So literally, as you're doing your slit lamp exam and you're going from right to left, if you stop right here, stop, collaborate, and look, and if you see these poking out little hairs, okay, just almost just vertically kind of coming out perpendicular to the nose bridge, and especially with patients that have rosacea, or even patients you don't see a lot of signs of Demodex blepharitis, she has associated that with Demodex. And if you can see in the picture there, she actually pulled a few of these little follicles, and you can see that the Demodex mites were in there. So she's done some treatment for these patients, and we'll talk about what the treatment options are that she puts patients through. But the reality is that you don't always have to look at the lashes or the lids to kind of diagnose these. Now, if you're not paying attention, okay, so check semblance, check. This slide to me is the money slide. And this to me is whenever I talk to patients, I feel like not only what's in it for me, Whiffle, what's in it for me? What's in it for me is that I get to look at a patient and say, hey, my job is to give you best quality of life. Okay? It's my job. And if I can do that, give you better quality of vision, then I'm going to do it. If I think you need to be in something, I'm going to tell you this is what you need to do. I titled this thing One is Too Much. Well, the one might basically, for all intent and purposes, is going to and has the potential to wreak havoc on your patient's vision. And the main reason why is these three things. When you think about a Demodex mite, okay, first and foremost is that they have mechanical, okay? So the lash, basically distension occurs, it attaches to the follicles, and what it does is it kind of creates almost just like little lacerations, if you will, because the mites have claws. They have 8 little claws, and I can go back and show you guys some pictures. So we create this mechanical kind of alteration. So the more of them, the 8 of them, kind of digging around in there blindly, right? They're creating little micro abrasions that is inducing inflammation. Okay. It's kind of creating this hostile environment in and around the follicle, but more importantly, at the base of the lashes. The second thing, and I'm going to skip bacterial, I'm going to go to chemical. The chemicals that are associated with this, they bring in cytokines, they bring in inflammation. Okay, the chemical kind of disruption that occurs can also be related to the fact that these little bad boys don't necessarily have they don't really have bouteilles, so it's been told, or so it's been assumed, that they don't regurgitate out the buttocks, but they kind of regurgitate out the front, or they just explode. Okay. In which case, all of that kind of juicy mechanical stuff that's in there comes out and creates these kind of like chemtrails, if you will. But the thing that intrigues me the most, and why I went from being a hater to probably a advocate more so than you'll ever realize, is the bacterial load that these carry. Now, they have 3 different types of bacteria. Okay. They basically have strep and they have staph. And those are both on the surface of the Demodex. Well, hate to break it to you kids, but you also have staph and strep. We have that common bacteria in our genome, so it's no big whoop, right? However, internally, they carry with them a unique bacteria called Bacillus olearum. We do not have Bacillus. Bacillus is not a common bacteria to us. So you now have a patient like my boy Bobby, who obviously has a ton of Demodex happening on his eyes. And it's leaving behind a lot of this bacillus. Now, you were taught when you were in school, or maybe even now, that when you see bubbles at the base of your lash, those little kind of little looking kind of almost like soap-like bubbles, saponification, if you will, that basically means that those are bacterial lipases that are breaking down the lipids and turning it into a soap. A lot of people talk about inspissated glands being because of that. A lot of people think that chalazion and hordeolums are because of the bacteria that basically induces that inflammatory reaction in those glands. Now imagine you're introducing a unique bacteria to the eye, and maybe a lot of it. So to me, I've really drawn a straight line between the meibomian gland dysfunction, the meibomian glands that we see, and the patients that I see who have MGD all day, every day. Their eyes look like crap. And yet I don't see a lot of saponification all the time. But the minute I see saponification, I'm looking hardcore for even one Demodex mite, collarettes, if you will. And I'm making that dry line because the key signs of this are just like dry eye. Okay. It's literally, misdirected lashes. It's itching. And that itching is usually here, but here's another ticker. How many of your patients will say, when they're on the computer, they just kind of feel like their eyes are tired. And what are they doing? They're rubbing. Or how many patients, when they wake up in the morning, they kind of just feel like there's sleep in their eye and they're rubbing their eyes. More importantly, we start to see erythema or eyelid inflammation. Some of these patients might have sensitivity to light, but also fluctuating vision. All of these things correlate to the thing that we should be managing is giving our patients the best opportunity to get the best quality of vision. And since we know that dry eye, meibomian gland dysfunction, call it what you shall, all of these things have, kind of a multifactorial effect, why would we not do everything we can to work on the lid? Because by managing the lid, we also, avoid disorders of the eyelashes. Now, I am a huge advocate for any patient out there who wants to wear extensions. You be you, boo. Okay, you be you. But at the same time, the minute I see an eyelid extension, my first thought is, you're not cleaning your lids. You're not doing anything for the base of your lashes. And I know you're never going to stop wearing them. So I have to do something to help keep you in there. I already mentioned meibomian gland dysfunction, but we also have things like, corneal manifestations. Like brevis is commonly associated with inflammation that spreads to the cornea, which can cause some slight, maybe some infiltrates or ulcerations. And the conjunctival inflammation that we see too, all of these things are fed by the lids. Now, I've kind of been dancing around a little bit about how to diagnose it because I wanted to give myself at least a good 20, 25 minutes of our time because it's challenging. Okay. And I know, if it was me, I would have said, let's do a 4-hour, workshop on diagnosing this condition because, it's really hard. You've seen the pictures, okay, that I've gone by. You've seen the base of the lash. Those are collarettes. You see a collarette, your patient has Demodex blepharitis. The work has already been done, my friends. Okay. People have been out there plucking lashes for you, validating that when you see a collarette, it is 100% pathognomonic. Okay. I love words like that, pathognomonic. I love things like, iatrogenic. I love, where people are like, what's that? And then it's like you have to stop and think about it. Kind of like, what's perla? My favorite story too to this day is I had an intern once who's like, it's and the pupils are perla. And I said, okay, well, what's perla? And then he's like, it's perla. And I said, don't know what a perla is. Can you define it for me? Well, it's when you say the pupils are normal, you call it perla. Now, the person that we were talking about had a prosthetic eye. I knew it, patient knew it. And so I looked at him, I said, well, let's assess this real quick. Pupils, what's the E stand for? And I go, equal. Yeah. Anywho. Yeah, he was crying before he left. But good times. But my point is that pathognomonic, meaning that it's a direct correlation. It is there 100%. The collarettes are, for all intent and purposes, these solidified exudates. They're the carcass, the shell, the poop. Call it what you want. And I do. I do. I literally told an 82-year-old dentist the other day, you know what? You've got debris. You've got dead carcass on the base of your lashes, and you probably got it since your mom was breastfeeding you. And you know what? He called and complained about that. You know what? What ifs? You got to be direct with these people, right? These are cylindrical dandruff, is what some people used to call them. It's not dandruff. It's a waxy formation at the base of the lash. You have 150 lashes. If you go through the lash cycle, which I can't even think of the three different phases, but one of the phases pushes the old lash out and the new lash comes in. So that's why sometimes you'll see the collarettes at kind of like further along the lashes than you would think would be at the base because the new lash is coming in. Okay, so they get displaced over the growth, and more importantly, these are just exploded Demodex. So everything that we've just talked about, all the chemicals, the inflammation, the irritation, the scratching, the whatever, it's all happening in real time, and you're looking at it and you can see it. So when you start thinking about it, is that this is not something that you can miss. And so the simplest way to do this, and I know this sounds trite, and I know we've probably talked about this, and some of you are here just for the CE, and you're like, dude, I know all this. And it's like, good, then do it. Literally, one of the things you need to be doing in your exam is walking in and saying, hey, how are you doing? And they say, I'm fine. You say, I have diarrhea. And then just say, drop your head in the set lamp. And the first thing you should do is just say, look it down. Because when you have your patient look straight, as you can see here in Elizabeth's patient, the same patient looks down, you add a little magnification, there is no way you can miss this. And to me, this is one of those things where once you see it, you can't unsee it. Am I right? Yeah, I'm right. Okay. And so the sad part is that there was a study that was done in 2023. This was from Optometric Trends, and only 66% of us say that we actually look for it in our routine eye exam. I'm sorry. Do you look at the cornea? Do you look at the iris? Do you look at the lens? I mean, I don't know about the retina. That's something different. But how do you not look at the lids? This should be 100% of the time we should be doing this. Okay. Here's a patient. Okay. Patient of mine. Yeah, this is the patient I took a picture of. I'm like looking at it straight on. I don't know. Does he have Demodex blepharitis? I don't know. I'm like, can you look down? I'm like, oh, nobody's ever asked me to look down before. Boom, looks down. Hey, and I hope y'all can see the Demodex collarettes there because he's got it. Oh, I went too fast. Hold on. Okay, here's another patient. Okay, look down. Do it. Do it. Look down. It's that simple. Okay. How about patients that have hooding? Okay. Can you tell this person right in the comment section? Yes or no? Demodex, yes or no? Yes, because I want to put it in here if they didn't. Yeah. When you have them look down, now you see that. Remember, we have 150 lashes on our upper lid. Okay. Oh, this picture didn't. I blew this picture up right before we did this. I blew it up too much. This is a kid who's like 23 years old. He had so much meibomian gland dysfunction. I actually was enrolling him into, oh, I'm sorry, Alicia, or is it Alicia? Aisha, that I was intense. Sorry about that. Is that literally I was enrolling him in a study for meibomian gland dysfunction. And as I was evaluating his meibomian gland, which was terrible, like terrible, I'm like, what is going on with this dude's lids? This is early 2020, 2021. And it's like, I pulled up his video that I had, and I'm like, holy moly, he has the worst Demodex I've ever seen. Okay. I mean, like every single lash looked like this. Now, I want to stop here for 10 seconds. And the reason why I want to stop is because I want to ask you something. If a patient came in to see you, okay? Oh, yeah. Okay. Yeah. Infestation. Terrible. If a patient came in to see you and you said, okay, look down, my man, and you see this, and then you say to them, how are you doing? And they said, I'm doing great. And they say, yeah, just came in for some classes, or my wife told me to come in, or my girlfriend made the appointment, or they both did. Awkward. My question to you is, how can you, as a clinician in good conscience, sit there and say, yeah, you're doing great? Okay, you can't. If you picked up a glass at a restaurant and it had all kinds of like little crap like this all over there, wouldn't you be like, can I get a cling blaster or something? Shouldn't your patient's eyelashes look that way too? Now, you may sit there and say, Mark, these are extreme. And yes, Aisha, they are extreme. But at the same time, too, though, you're seeing a snapshot of these patients' lashes. Okay. So, how do you discuss this to patients? Well, there is a common misconception that somehow our patients is poor hygiene. Okay. Moreover, patients, don't always understand that there could be mites that are causing this. And a lot of patients worry about the treatment process being challenging. For me, what I like to do is I like to go at them hardcore. When I'm evaluating a patient, and the first thing I do is I say, look down. I will say to them, I'm seeing something that we have to address. Or I noticed something on your lids that we're going to talk about in a couple seconds. Look up, look down, do all those things. Okay. And when I pull them back, I look at them and I say, look, you know what? Before we talk about your glasses or refractive surgery options or cataracts, you have a condition that we call blepharitis. Now, we have bacteria, we have viruses that share our little, meat bag here, but we also have little mites. And yeah, I get the gamut, friends. I get people going, and other people going, and I go, oh, I've seen the commercials. But I look at them and I basically just tell them, look, I go, you know what? You have a skin mite, it resides on the skin, your forehead, your neck, but the biggest place it also resides is on your eyelashes. And you have an overproduction of them. And I'm seeing that that has the potential to be changing the quality of your vision. Moreover, it could make your lashes fall out. It can cause itching or irritation. Or you said to me, you noticed your vision's fluctuating. I feel that this is contributing to it. When you have a discussion where you go, face first, tell them what you're seeing, is that then you have to come back and say, but you know what? We have a treatment and I have something that's going to help you. Now, when we're talking about this disease state, a lot of times we would have patients go home and do tea tree oil, and that's great. The problem with tea tree oil is that it burns like a mofo. More importantly, patients suck at doing things. I mean, the adherence to doing anything is terrible, and you guys know it. Okay, I'm a Pelotonian. Okay, I've ridden my Peloton bike almost every day since I got it in 2020, 2019. How many of you guys have a piece of equipment in your house that you're like, oh yeah, I should start doing that again? Now imagine your patients have to wipe their lashes and their lids. Not doing it. Not doing it. More importantly, the amount of wiping and the amount of treatment, all that's going to do is maybe eradicate the mites or clean off the collarettes. That's another thing I tell patients is that, you know what? Oftentimes, just by using lid wipes, all you're doing is moving the mouse droppings away, but you're not killing the mice. Now, there's in-office procedures they can do, like intense pulse light, and that does work on the exoskeleton of the Demodex mites. The problem is that it's a life cycle of 3 weeks. So then the eggs are going to come back. Your patients are going to come back for another treatment. Okay, so, and I get it. I mean, I don't know how much patients want to spend, how much they're going to spend, but it does help, and more importantly, we need something that's going to eradicate them. Okay. So the drawbacks, as I just described, more importantly, the tea tree oil damages human epithelial cells in the meibomian glands. That was a study done by Chen. So we need to find something. Now, you probably saw that this was a grant that was sponsored by a pharmaceutical company called Tarsus. Ever so often, it's easy to talk about a condition that has only one treatment option. One. When we come in and you get people coming on woo you, woo woo, talking about dry eye treatments. There is a plethora of dry treatments. In fact, there was a new one that was just approved last week. And so you have to kind of figure out who those patients are and who's going to benefit from them and who is going to accept the side effects, who is going to affect, what the indications are. With this disease state, there's one treatment, and that's lotilaner. Lotilaner ophthalmic solution is the only treatment that you have. It was FDA approved in 2023. I told you my boy Bobby came in to see me in August. It was August or September. I brought him into the office and I said, B man, I go, there's a drug coming out. I said, I think we need to get rid of these mites. I think we need to maybe clean off your Demodex. And he goes, you've never mentioned this before. And I said, are you sure? And he goes, yeah. And I go, wow, okay. I have a lot of patients now who say, how come the doctor before didn't mention it? And I go, because they're stupid. They go, well, it was you. And I go, anyways. So what this medication does, Bobby, is that it paralyzes the mites. Okay. It basically has a non-competitive antagonist for their GABA chlorine channels, which causes it to essentially freeze, paralyze, and die. Moreover, it comes in this lipophilic kind of molecule that basically allows it to smoothly get inside the eye. They did a couple really awesome long trials. Okay, 2 6-week randomized multi-center double mass vehicle controlled studies, 833 patients. They were randomized to either lotilaner or a vehicle. Now, something else about lotilaner that I think is important for you to remember is that this is essentially a veterinary medicine. So there is Demodex scabies, which is essentially kind of, if you have a dog or a cat, they have scabies. I personally would have put them down, not a pet person, but you can get lotilaner lotion that you can put on them, and it actually acts the exact same way. So in this study, what they did is they randomized them to the lotilaner or to the vehicle 1-to-1. Now, one of the things that they did is they made sure that they pulled collarettes, lashes, to make sure that they had Demodex mites in the follicle. Secondly, they counted how many they had in there. So you had people that were counting how many mites there were, and more importantly, they were also looking for to make sure that they have them 100%. So their primary endpoint was a eradication of the mites to less than 2 collarettes, 150 lashes, less than 2. Okay, that's ground zero. But basically looking at the follicles and saying there's no more mites inside the follicles. That's another one. Okay. The third one was a secondary, was looking at erythema. And then they did an ad hoc where they were basically looking to see if we said, what if we just did, less than 10? If we brought them down to like less than 10, how did they do? Okay. So when you look right here, okay, 50% compared to the vehicle of 10% at the 6-week course. This is a twice a day, 6-week course. And you remember what I said to you when I told patients, look, you know what, you've got this disease, you've got this blepharitis, we're going to manage it. But more importantly, what's nice is we now have a treatment. It's for 6 weeks and it's twice a day. Patients love finite. They like to know that there is a beginning and an end. And so when we look at these pictures here that came directly from the clinical trial, okay, you see Elizabeth Yu's name there, the average baseline was 100 collarettes. So in order to be in the clinical study, you had to be 10 collarettes or less. But the average patient had 100. And the 100 picture looks just like the one on the left. And that 50% of these were down to 2. That is cray at that 6 weeks. Okay, went too fast here. When we start looking here at the specific data, you can see how it broke out between the 2 different studies, between Saturn 1, Saturn 2, and the different vehicles, and you see their primary endpoints. Second thing, complete eradication. So you see the menage a trois that's happening over on the left side there. The average baseline had 3 mites, three mites per follicle. Okay. And in order to get it down to 0, 60% of these compared to 16% with the vehicle, 60% got down to 0. Okay. And here's the data broken out for any of my data nerds out there. And then a secondary endpoint is erythema. And I kind of don't want to steal thunder from a good friend, Paul, but Paul's going to talk to you about a study that came later, and it was called the RHEA study. And in this study, it was basically a satellite study looking at patients who had Demodex, but also had meibomian gland dysfunction. And in this study, by the way, RHEA is a moon that travels around Saturn. In this study, they did a visual analog score. Now, for those of you, when I say visual analog score, if you are like me, I get hung up on the word vision. And I'm thinking vision, like as in 2020, 2015. No, visual analog scores have nothing to do with the vision. That has to do with seeing the score. And literally, it's kind of like the Wong Baker. where you have your patients just put a little mark next to the sad face or the happy face. It's a line that is 100 millimeters or 10 centimeters. On one side, it says, my eyes are white as the driven snow. And on the other side, it says, my eyes are red as, I don't know, blood. And so you have a patient put an X where they think they are. So the lower the number, the better they are. The higher the number, the worse they are. To me, a visual analog score really, to me, gives a better indication as to what my patient's perception is, not my perception. Because I will walk into a lane and a patient goes, my eyes are so red. And I'm like, which eyes? And they're like, these. And I'm like, huh? It's like, do you ever do that where you see patients who are like, oh my God, I have these like bumps? And I'm like, wow. And it's like, don't you see them? And I'm like, no. But you almost kind of have to go, oh, I see what you're saying. Yeah, no, I don't. So in this study, the average baseline was a 2. You can see it there. To me, the grade 1 almost looks like a grade 0, but who am I? So the fact that they were only able to demonstrate 25%, okay, then you know what? I think that's good because Paul's going to show you in that other study where the patients themselves said, yo, it looks good. That number was like twice as much, like 30 or 40% patients had the perception that the erythema was actually better. So I think this number is low. Okay. And it's also, to me, not that important. But the collarette reduction is because you're killing these buggers. And when we started with an average of 100, and I said, what about 3 to 10? And 3 to 10 was to get in the study. Okay. 3 to 10, 85%. 85% of these patients reduced 100 down to that. So we know this works. Do I bring these patients back? No. Do I love my patients? I do not bring them back. There's no reason to bring them back because you know that you've done it. You've treated them. And when you look here, day 56 and day 43, the average amount of collarettes that are down to less than 10, that number is clinically significant and it's ridiculously high. Okay. The bigger thing is that when you prescribe this medication, 90%, 90% of patients basically in both trials said it was really neutral to comfortable. I do not have patients calling and saying, hi, that medication you prescribed for me, that thing burns like a mofo. I hate you. Nope. I don't have patients calling and saying, ooh, you nasty. Ooh, I mean, they don't. The challenge sometimes is getting the drug for the patient, but once they have it and use it. And the nice thing about it too now is that, they can get a refill after the 6 weeks. And because 85% of these patients are down to 10, okay, and that number down to like 0 to 2 is lower, sometimes for patients that have crazy amount of collarettes, I will tell them to use it longer. But the craziest thing to me is that patients start to tell you things that they didn't even realize. They'll say things like, you know what, my eyes feel good, or my dry eye feels better, or my vision doesn't seem like it's fluctuating as much. And so it's symptoms that you didn't know you had by basically treating this condition. Couple takeaways, okay? First and foremost is that there is a clinical study that was being done comparing these with contact lens intolerance. The data will soon to be released, but if you saw before that 90% of patients who had Demodex also had collarettes, why would you not be looking to try to manage the Demodex on your patients that have contact lenses to help keep them in there longer? Okay, 1 is too much. 2 is that patients that have an excessive amount of meibomian gland dysfunction, okay, those are patients that if you think about that bacterial load that we just talked about, if you think about, the treatment options and opportunities that we have for meibomian gland dysfunction, wouldn't it also benefit you to take somebody and help manage that condition if they have Demodex blepharitis? But the other thing that I really, 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 tell me what you want, what you really, really want, is I want you to associate Demodex with hordeolums. There has been a good amount of data to suggest that. And more importantly, when you think about, where these mites reside, it only makes sense that they have a contributory factor to your patients that are developing hordeomes. So you have patients with multiple hordeomes or recurrent hordeomes. Now, I'm not saying don't be cautious of the sebaceous adenocarcinoma, that chalazion that kind of doesn't go away or keeps coming back after about, 3 years. Maybe send those patients out for a biopsy. But Bobby came in to see me. I started him on the drug. Okay. I did not hear back from Bobby until August of 2024. He sends me a text. Still have the text. Why? Because I'm stupid about erasing stuff. And he says to me, he goes, I'm starting to get another one of those bumps. He goes, can I start using lotilaner? To which point I said, hell's yes. To which point he said, good, I already started it because the bottle's overfilled. He said, can I get a refill? And I said, of course. 3 days. Uno, dos, tres, cuatro. Uno, dos, tres, catorce. Okay. There's a lot of uno, dos, treses in songs. Did you guys notice that? I just did that. That was you too there, if you didn't notice that. He said after 3 days, his exact words, this is a miracle drug. He does not call me anymore. I guess he doesn't want Oakley's. That's okay. You be you, boo. I sent him a text not that long ago and I said, how are the eyes doing? He goes, they're doing great. He goes, why didn't we start doing this sooner? To which point I said we couldn't. To which point I then ghosted him. Yeah, don't need that. I don't need that. I don't need that in my life. Right. But I led him to a phenomenal treatment. He's not getting any more problems. Let's leave it what it is. So often misdiagnosed and underdiagnosed. Have your patients looked down. Okay. You want to eradicate the root cause. There's really only really one good way to do that. Now you may say, Mark, do you still do, lid scrubs? Do you do blepharo exfoliation? Sure, I still do. I mean, I will still tell patients that have a lot that as the mites start to come back, because remember the key takeaway here is telling your patients, look, they're on your skin. So all we're doing is removing them from the eyelids, but they're going to come back. And the best analogy, to me, the best one still is plaque on your teeth. Okay. Every one of us goes and gets our teeth cleaned. If you don't, you're thinking, are you British? So you need to kind of give your patients that expectation. When you come back, we'll look at it again. We'll see what we need to do. Okay. So knowing that this medication, can and has the opportunity to eradicate these and to successfully treat these, you now have an opportunity to help your patients.